but we will try to finish as close to on time as we can. We'll probably go a few minutes over so we have discussion. But I'm pleased to introduce my co-moderator, Vishali Gupta, for this session. We have a good group of talks, and the first lecture is going to be given by Glenn Jaffe, and his talk is entitled Deep Learning Approaches to Assess Macular Telangiectasia Progression. So if we can have Glenn's slides up, it'd be great.
Thank you very much, Vas, and I'm very pleased to be able to discuss how you can apply deep learning approaches to quantify changes in ellipsoid zone area in diseases like macular telangiectasia. And by way of disclosure, I have consulted for Heidelberg. During this talk, I'm going to be using the term ellipsoid zone rather than intersegment, outer segment junction, recognizing that there's controversy over the use even as we speak, but for consistency, I'm going to use the term ellipsoid zone. As I think all of you know, in this condition, which is thought to be driven by abnormalities in Mueller cells, there are cavitations, there is disruption of the ellipsoid zone, and that disruption of the ellipsoid zone correlates with losses of function. And so in previous papers, it's been shown that if you overlay the microperimetry on top of these ellipsoid zone defects, that the two correlate. But this was using manual segmentation. And so here's an example of an OCT B-scan cross-section that was segmented, and when you serially segment each of those cross-sections, you can generate an en face map of the defect area. Well, that's very time-consuming, it's very labor-intensive, and it's not very practical if you're trying to run a large clinical trial or if you're trying to assess this in the clinic. And so we undertook a project to automate the measurement of the ellipsoid zone loss to be able to then register the OCT with the microperimetry so that you could overlay the loss area on the OCT with the microperimetry defect to correlate the structure and function changes. And then the next phase was to enhance this process with a deep learning approach to see if we could use this in the clinic and in clinical trials. So for the first step, the idea was to automate the detection of the ellipsoid zone loss. And there's some obstacles to doing that. There are potential registration artifacts, resolution may be an issue, and there's maybe inadequate scan density. So this just illustrates one of the issues here with axial motion artifacts. So if you look at these sequential B scans, you see that they're not registered in the axial direction with one another, which leads to this bumpy looking surface map down below. You can overcome this with eye tracking, with high resolution images, with high density scanning. At Duke, custom software has been developed called the Duke OCT Retinal Analysis Program, or DocTrap. And with this software, you can automatically segment retinal layers both in normal eyes, but also in diseases. And when you look at this eye that has macular edema, you see that the yellow line going across has a defect in it. I don't have much of a pointer here, but I think you can recognize in the very center there's a loss of ellipsoid zone that was identified automatically with the software. Well, why is it important to try and quantify these defects? It's because, as I've mentioned, the structure correlates with the function. So the first part of this approach was to create an en face, thank you. Yeah, that's better. To create an en face OCT reconstruction. So the idea, rather than manually outlining each of the layers, was to use a semi-automatic ellipsoid zone loss area segmentation, and then to correct it. This one's fine. No, I've got it back. That's okay. So for the en face reconstruction, it's derived from the B-scan. The thickness of the ellipsoid zone is measured, and you can set a thickness threshold, and below that threshold, you would consider that the ellipsoid zone is disrupted, and then you can display that as a 2D map. So on your left, you see that this image was segmented automatically by the software, and then the series of B-scans was then redisplayed in this 2D image. You can do this in 3 dimensions, which you see here, or do a binary map, and then you can monitor this over time and look at the change in ellipsoid zone loss over time. So the next step after doing this semi-automatically was to then register the OCT with the microperimetry. And so to do this, the sizes of these images are different. And so if you want to overlay the one over the other, you have to warp one onto the other. And to do that, we used the retinal blood vessels to map from the scanning laser ophthalmoscopic image that went with the OCT to the fundus image that accompanied the microperimetry map. And then you can overlay, after you do the warping process, the blood vessels are very well registered. And then once they're registered, you can then overlay the ellipsoid zone loss area with the microperimetry sensitivity loss. So you see some of the microperimetry sensitivities. These are interpolated to smooth them out. And so on the top, you see the microperimetry. Here you see the interpolated map that's binarized, so this is with a threshold. And then you can overlay that onto the binarized ellipsoid zone loss, and you see they overlay very well. And so then the question is, in a larger series, how well does this structure-function correlation work? And so this was a MACTEL phase 2 study comparing CNTF, the neurotrophic factor, to sham injection. And in this study, we looked at the aggregate sensitivity inside the ellipsoid zone loss area, inside and outside, to correlate the two. And you see there's a very tight correlation. So here you see the defect area, and here you see the red and the yellow and the dark, or the microperimetry loss areas. Still, though, this is somewhat labor intensive. When we do the dog trap method of segmenting, that's a semi-automatic method because we have to still do manual correction of the segmentation errors. It'd be nice if you didn't have to do any segmentation at all, and that was the next phase, to enhance that with a deep learning approach. And Jessica Liu is a graduate student that is working under the guidance of Sina Farsu, one of my co-faculty members at Duke. And they developed an algorithm called DocTAD, which is Deep OCT Atrophy Detection is the acronym. And it uses these clusters of volumes of A scans run through a convolutional neural network, and then you output the probability. So rather than, this is not a segmentation map, this is a probability map that you have a defect area. And this is either defect or no defect. Here's the defect and there's no defect. And this was compared to the other methods, including manual segmentation. They were compared to the manual segmentation, which was used as the gold standard. And then DocTrap, this was automatic segmentation with no manual correction. And then at the other end of the extreme was the DocTAD method. And the DICE score is an indication of how well the gold standard manual segmentation correlates with these automated methods. And you'll see at the one end of the extreme, DocTrap, a perfect score is 1. And this, the DocTrap was very low. This is with no correction. There were a lot of segmentation errors compared to DocTAD, which was 0.87, which was very high. So this showed that the deep learning approach, without any segmentation at all, could achieve a result that was very highly correlated with the manual measurements. And so here you see these. Green are the true positives, and red are the false negatives. And you'll see that the ellipsoid zone measurement was basically green with DocTrap, showing good true positives, whereas you see these red bars with the other methods. And then we can improve on that further by using the individual's own baseline segmentation, baseline probability map to tune the convolutional network to enhance the ability at subsequent visits. So we're using the previous area probability maps to predict or to help tune the convolutional network. And so you can get even better when you do that. So here you see before this tuning, and then after, especially in this one, these red dots are the errors, and after it's tuned, you see these errors go away. You have these false negatives, and then you have they go away after you do the tuning. And so for an individual, the blue is the DICE score, and you see the DICE score getting better and better. These are the total errors going down as you use the transfer learning based on the baseline value to help tune the subsequent visits. So how does this actually work? This was done in a clinical trial. This is the MACTEL trial results, that CNTF trial, and there was a positive result using the manual segmentation. This was the method that was used in the trial. And what you see is that there was a difference in the CNTF treated group compared to the sham group. And this is what you're trying to do, is slow the growth of the ellipsoid zone loss. With the automatic deep learning approach, we got the same result basically. And that shows that you can, in a clinical trial, identify the same positive outcome that took a lot of manual adjustment of the segmentations with this deep learning approach. So to summarize this, it is possible to segment these ellipsoid zones automatically. You can register that with the Micro Perimetry to do the structure-function correlation. There was excellent correlation but these methods were enhanced with the deep learning approach, which takes a lot of this manual correction out of the equation. And I think it really does support the ellipsoid zone loss as an endpoint in clinical trials. And automatic methods for clinical trials for diseases like Stargardt's disease and others where ellipsoid zone loss is prominent, I think is very realistic. Thank you.
Thanks very much, Glenn. We're going to have a Q&A session at the end, so we'll move on to the next presentation from Bailey Freund, Dense B-Scan OCT Angiography.
Thank you, Vas, and I want to thank the VRSI for inviting me to be part of this program. So I'm going to be speaking about a technique that we recently published on. It's called Dense B-Scan OCT Angiography. A little bit of background first. To date, most of the development of OCTA has been focused on the en-face visualizations, and I think the instrument manufacturers are just moving towards trying to create an OCTA image that resembles an angiogram, and I think that's not necessarily always the best way to look at OCTA data. You know, they've gotten very good at this. This is a technique called enhanced extended field imaging, and so we've gotten very wide angle OCT images on some of the swept source devices. But as a result of this trend, the quality of the structural B scans has remained rather poor due to the limited averaging that can be done in these very large wide angle volumes. If we blow up the structural OCT B scan with the flow overlay, we can see that it just doesn't have the same quality we're used to when we look at the averaged structural OCTs on our regular clinical devices. And there's an inherent limitation of swept source, although it's faster. The axial resolution is lower because of the longer wavelength. This is just examples of the structural B scans with flow overlay on 4 of the commercially available OCTA devices. You can see that the OptaView is probably the one that looks the best, and that's because there's more averaging. It's also a spectral domain device. This is the Heidelberg Spectralis OCT2. That's just the OCT B scan that you get with the commercial release. So what I asked Heidelberg to do is I wanted them to forget about giving me a wide angle view and focus on just giving me the best possible structural image with the flow overlay. So the way that was accomplished was by using the rather precise tracking of that device and just doing a high amount of averaging, doing scans very tightly spaced, and then averaging adjacent scans. So they created a software that could do 200 or 300 average scans within just 1 degree. And so that takes an image that looks like that to a much sort of higher level, where to me this gives me much greater confidence that what I'm looking at is the individual capillaries within the retinal structure, and you can clearly see the 3 plexuses, superficial, intermediate, and deep. So I think for certain diseases, that's quite helpful. This is a montage of 220-degree dense B-scan OCTAs of my eye. So here's a case of aneurysmal type 1. That's the name that Vas and I use, and David as well, for what most people refer to as polypoidal choroidal vasculopathy. Here's the scan with the swept source plex elite, and this is the same eye image with dense B-scan OCTA. Note that you can place these scans wherever you want at any angle, and you can do track scans so you can follow pathology over time. So that's just looking at one of these aneurysms, and one of our fellows from Japan had a project where he was using this to try to get a better sense of how these lesions are really fed and drained and what parts of them actually contain flow. We looked at this entity, LEP, or lamellar hole-associated epiretinal proliferation, because there had been one or two papers in the literature that suggested that there was vascularity to these lesions. And you can see that we can look at that issue very precisely because we can detect just tiny flow in individual capillaries, and there doesn't appear to be any flow in this, what is presumably a glial proliferation, possibly Mueller cells growing onto the retinal surface. Here's just another example of lamellar hole-associated epiretinal proliferation. Here's a case, and I want David to pay attention, okay? So this is a patient with AMD where I've used this technique. I'll show it at the end. So this is a patient that I've followed since 2005. And so here's what happened over 10 years. This is 10 years of tracked follow-up after this patient developed type 3 neovascularization, which we all know often progresses to relentless geographic atrophy, or CRORA. That's the new terminology. Now let's ask this question. Is there a way that we could prevent this from happening in the patient's fellow eye? So here's the patient's tracked near-infrared reflectance images over the last 3 years. And notice that there is sparing of the RPE at the fovea. So what accounts for that sparing? Here's what I've been doing with this patient. I'm using a modified treat and extend regimen where I'm actually trying to promote the growth of sub-RP neovascularizations. I'm going to just go back and so see that I've gone to longer intervals to allow fluid. I'm trying to get this lesion to grow more under this patient's fovea. So that's me with my little hedge clippers, where our tools are that we can adjust the interval, we can adjust the drug. And so I'm not treating to the point of dryness. I'm actually trying to do something that's a little risky, get that lesion to grow larger, and because I think there's a protective effect. So in 2010, in this editorial with two of my fellows, we hypothesized that type 1 neovascularization could actually help prevent atrophy, because it's more of a compensatory type of neovascular proliferation. That's something that was proposed by Hans Gross-Nicholas and Dick Green. So here's the dense B scan as of just a week or two ago. His vision is until 2025. And I don't think this patient is going to develop foveal atrophy. I think once you have that lesion, you're protected from atrophy. Now, how do we get that to happen in more cases? Well, that's hard. But if you have this opportunity, don't squander it. Let it happen. All right, the last entity I want to discuss with the use of dense B-scan OCTA is what I call type 3 neovascularization. This is a clinical pathologic correlation showing what is probably the most important aspect of type 3, which is this, what I'm pointing out there, basolaminar deposit. These eyes have very thick basolaminar deposit, and Mueller cells and the vascular elements penetrate through that, and that's what forms the adhesion between the outer retina and the underlying tissue. It's not an adhesion to RP, it's an adhesion to basolaminar deposit, and that's why they always look like this. Here's the flow overlaid onto that, and you can see the thick basolaminar deposit as the splitting of the RPE and Bruch's complex. All of these eyes have this, and really, to me, what defines this entity is that not only is there intraretinal neovascularization, there's implantation of Mueller cells through a defect in the RP into this basolaminar deposit, and that's really never going to separate. And that's the true type 3 right there. So this is just a tracked patient where I just follow it. It's very easy to know exactly where I need to look, just one little area. When the fluid's there, I treat, and then it usually comes back, every 3 or 4 months. And there's the basolaminar deposit, and again, there's the how I now define type 3 neovascularization. This is not type 3. This is actually something known as PVAC, described by Giuseppe Kerkis. It's just a microvascular abnormality or aneurysm, and in some patients, it develops in the same type of patients that develop type 3. Here's a true case of type 3. There's 2 lesions here. You can see the lesions implanted into the basolaminar deposit through the defect in RPE, the flow right there. You can see the pre and post treatment imaging. The little red spots have sort of involuted. That's pre and that's post-treatment. You can see the flow subsides, and it predictably will come back at certain intervals. And it's very easy to just do this track scan. You know exactly where to look. And I usually do OCT guided because I'm comfortable knowing where to look. Here's another case of a true type 3, developing an area of C-RORA or atrophy. So first you get the atrophy, and then you get the implantation of the Mueller cell processes and vessels into the basal laminar deposit. You can see that very nicely with the dense B-scan OCTA technique. This is color coding the 3 vascular plexuses. You can see them now being superimposed on the larger wide field swept source OCTA that's been depth encoded. The blue area is the deep lesion. So in summary, with dense B-scan OCTA, we can do very precise correlations between retinal microstructure and blood flow, and the ability to accurately align and follow these lesions, I think, has a great potential in giving us a better understanding of different entities that require this degree of precision, and I think will prove helpful in management in a select group of images. So I appreciate the attention and the opportunity to present this. Thank you.
Thanks very much, Bailey, for that nice presentation. Again, we'll have questions at the end. We'll move on to the next presenter. Vishali Gupta will present on fractal dimension analysis of OCTA for retinal pathologies.
Thank you, Vas. I shall be talking on fractal analysis on OCTA images for retinal pathologies. We all understand a number of retinal pathologies do result in vascular changes and alterations that affect the perfusion and cause anomalies like choroidal neovascularization. Using OCT and OCT angiography now, it's possible to visualize these neovascular networks, and we are all looking for imaging biomarkers to predict, treat early, and preserve vision. When we are looking at the biomarkers, the most important biomarker that we see on OCT is the presence of fluid. Whereas when we go on to OCT angiography, we don't see fluid. So we are trying to look for a marker that can help us differentiate the active from so-called treatment-naive, quiescent, or inactive choroidal neovascularizations. So there is this concept of fractal analysis, which is a method in which image analysis of human retinal network can be done, and it plays a key role in identifying the health status of retinal vessels. It gives you a range between 0 to 2. So if you have a higher value, that indicates increased pattern of complexity, and the smaller value indicates there is disruption of retinal vessels, something that can be applied in your day-to-day practices. Now we go back to the utility of fractal analysis in retinal diseases. This fractal geometry provides a more accurate description of human retina vascular network than the usual Euclidean geometry, and this can be used as a part of screening tool for early detection of retinal diseases. The examples where it can be used, it has been shown to decreased vascularity both in superficial and deep plexus in patients with diabetic retinopathy. So in day-to-day practice, how it can be applied? It can be applied to choroidal neovascularization. These choroidal neovascularizations can be active, they can be treatment-naive, quiescent, they can be regressed, or it could be just a scar. So it's important to study the geometry in order to differentiate or classify them into these different categories. Now, this case shows a 65-year-old man, low vision, and has received 2 injections, and as you can make out in B-scan, it is an active neovascular membrane, which is type 2 intraretinal spaces. So if we do look at the OCT angio, there is a complex network of vessels with significant branching. And fractal analysis is 1.7, which means it's a complex branching and it's an active lesion. Compared it to a relatively inactive CNV in a patient who has already received 13 injections in the past and is presently fluid-free on OCT. Now, when we look at the OCT angiogram, we do see something which looks inactive, and the fractal analysis is 1, which is close to 0. That kind of gives you a confidence that this complex branching is, so less complex branching is suggestive of inactive CNV. So morphologically, you can have active, inactive, treatment naive, regressed, and fibrotic, and it's all based on studying the geometry of these new vessels. And if you wish, the fractal index could be combined into this. We have also done the application of this fractal analysis post-retinal detachment surgeries. So we all know that patients with macula of reg RD do not gain vision even after the retina gets successfully reattached. However, microvascular changes in the macula following reattachment have not been adequately studied. So using OCTA, we evaluated retinal vasculature in subjects who had undergone surgery. So in a case control study, we had OCTA findings of 20 eyes of 20 patients who had undergone a single reg RD surgery, whether it was a buccal or a gas, and compared it with the normal age and gender matched healthy subjects who had no ocular or systemic disease. Patients undergoing silicone oil tamponade were excluded, and patients with severe proliferative PVR, subretinal fibrosis, bands, macular hole, glaucoma, atrophy, or prior surgical intervention too were excluded. We had 3x3 mm OCTA scans using the OptiView, and all of them also had fundus photography and OCT. This is just to give you an example of one of the pre and after scleral buccal. So using a previously published methodology, image binarization was performed and processing was done using a third-party software, ImageJ. And from the total retinal area, the luminal area was highlighted by applying color threshold. The stromal area represented the vessels and the interstitium, and the vascularity index was calculated as a ratio between the luminal area and total retinal area, quadrant-wise, dividing the central 1.5 mm into 4 quadrants. So the mean duration of the visual symptoms, that is the duration of the reg RD prior to surgery, was about 1.43 plus minus 1.73 months. And amongst patients who were recruited in the study, 11 had undergone vitrectomy and 9 primary scleral buckling. 8 were pseudophakic at the time of reg RD surgery. Patients with reg RD showed an evidence of increased intercapillary spacing on NFAS OCT angiography. The mean vascularity index amongst patients was 33.5% and 33.69% in the superficial and deep retinal plexus, respectively, as compared to 58.46% and 62.49% amongst controls, which was found to be significant statistically too. So these patients following the successful repair had decreased vascularity, increased intracapillary spacing, both in the superficial and deep retinal layers. And this is the example of OCT, superficial capillary plexus, in the patient compared to a healthy control. So the quantitative analysis on fluid density in each quadrant showed that vascularity index in each quadrant was decreased compared to the vascularity index in the healthy control. And if we look at the global vascularity index, it was 33.5 plus minus 1.04 in patients compared to 58.46 in controls. Not only in the superficial, but also in the deep capillary plexus, there was the difference between the patients and the controls, and that too showed the same pattern with a reduction that was statistically significant in patients compared to the healthy controls. So our findings in this suggest that retinovascular changes with remodeling may lead to photoreceptor damage and hence suboptimal visual gain after a successful Regardie surgery. So post-surgical photoreceptor degeneration and vascular alterations may also be related to the inflammation that occurs during the Regardie. So this we have published in August issue of Retina this year, and I'm thankful to my co-investigators, especially Anirudh Agarwal, for doing all the hard work. Thank you.
Thanks very much, Vishali. We'll move on to the next presentation, and this is from David Sarraf, entitled En face OCT, Advanced Retinal Imaging of Macular Disease.
Thank you very much, Vas, and to the organizers of VRSI for the invitation to be here and to speak on en face OCT and our utilization of this relatively new, innovative modality for the assessment and diagnosis of macular disease. So en face, Glenn very nicely, I think, summarized the methodology and the importance of en face OCT and segmenting the ellipsoid and MacTel. We'll give you a little bit more of a general overview of this modality. And essentially what we do, we take a volume, a high-density volume of cross-sectional B scans, and we reconstitute or reconstruct that volume of information, that very large volume of information, onto a coronal or en face plane. And we use the binary reflectivity to reconstruct the lesions that we see on B scan OCT, so that we can identify the pattern and relationship of the hyper and hyporeflective lesions that we see on the B scan OCT. And in addition, this gives us depth segmentation so that we can actually see the pattern of pathology at a specific layer of the retina. And there are many ways in research and in clinical application in which I find en face OCT to be very valuable. Recently, this work we've done with Eduardo Navajas at UBC and Andrea Govetto in Milan was very important in using en face OCT. And you can see in this particular study, what we were able to do is take these patients who had had epiretinal membrane peeling and identify the development of intraretinal dimplings, intraretinal dimples or dissociated nerve fiber layer on a sequential basis. And you can see that we actually identify these lesions first at 1 month, and then with sequential follow-up with en face OCT, you can see a progressive increase in the number and size of these lesions over time until 6 months, at which time they become stable. And we have several cases. This is now in press in retina, and you can see that same similar timeline, noting that you don't see the dimples at 0 to 1 month. And another example showing, again, the development at 1 month, progression up to 6 months, and then stabilization thereafter in all of these cases. And we studied these cases, and we attempted to explain this progression. And we looked at nerve fiber layer edema, and how we explained it is that there's initially nerve fiber layer edema in the first month after surgery. This hides or obscures the identification of these dimples. After nerve fiber layer resolves at 1 month, you can then uncover these intraretinal dimples. So en face OCT, very helpful to identify this pathology and the sequence and progression of this pathology. This is a 13-year-old young lady who had a neovascular lesion here, type 2 neovascular lesion, and you can see these extensions, these little spikes that have this pitchfork appearance that actually Bailey first described a few years ago. and there's subretinal fluid. There you can see the pitchfork sign, which has been associated with type 2 neovascularization. But more recently, we were able to take a number of these lesions. Khalil Falabrajani in Tehran, Iran, was able to do en face OCT. And in fact, you can see that these pitchfork lesions actually are present around the entire circumference of the type 2 neovascular lesion. And they actually look like a wreath or a spiked crown. And here's the case when we do OCTA. You can see the neovascular lesion with the definite flow signal right here. In this particular case, we treated with anti-VEGF, and you can see actually resolution of the lesion. It actually went from a type 2 to a type 1 lesion with encapsulation of the RPE, which has been previously published by K.Bailey and myself several years ago. And this was a process that we saw in actually all of our type 2 cases. They all had this beautiful appearance on en face OCT, and they all went from a type 2 to a type 1 lesion after anti-VEGF therapy. But en face OCT was very nice to see the pattern or the relationship of these extensions much better by plotting onto a coronal plane. And you can see one more example of this pitchfork sign looking more like a wreath sign with en face OCT. PAM, of course, we talked a little bit about this yesterday, is a very important entity in terms of using en face OCT. Initially, as we described it, it was a hyperreflective band at the level of the internuclear layer, which represents an infarct of the internuclear layer because of deep capillary ischemia. These bands, just like cotton wool spots, which are more superficial, lead to thinning or a legacy of thinning in the same area. But when you plot these lesions actually onto an en face plane, you can actually see various patterns. They can be globular or, as in this case, perivenular. And in fact, CRVO patients, even CRAO patients, not uncommonly can present with perivenular PAM lesions. And if you do an arterial venous plot, you'll see that the hyperreflective lesions on the en face OCT have a precise perivenular distribution, as in all of these cases. Here's another case where we did en face OCT at the level of the outer plexiform. You can see CME. When we move that segmentation into the internuclear layer, you can see all the hyperreflective fern-like PAM lesions, again with an exclusive perivenular distribution, in this case of CRVO. And then when we overlay the fluorescein angiogram to identify the arteries and the veins, we can plot the precise distribution of these perivenular PAM lesions precisely along the veins. And in fact, there can be a spectrum of perivenular PAM change associated with both CRVO and CRAO. We believe that this relates to an ischemic cascade. And here again, you can see a patient with perivenular PAM lesions from a cilioretinal artery obstruction progress to a globular PAM lesion within 12 hours. And what we feel this relates to is an ischemic cascade in which ischemia and infarction first develops at the perivenular pole of the deep plexus, which is at greatest risk of lower oxygen saturation levels. And with more severe ischemic injury, you will have progression through the deep plexus and into the inner retina, which is the most resistant to infarction because of its proximity to the arterial circulation. White dot syndromes can also be very nicely elucidated with en face imaging. In this particular case, you can see these hyperreflective dots overlaid on hyporeflective spots. And this is actually very characteristic of MUDs. And in MUDs here, you can see these large hyporeflective spots. These co-localize beautifully with the hyper autofluorescence spots that you see with fundus autofluorescence. That's very characteristic of MUDs. And again, you can see the co-localization with fluorescein angiography, and then the hyporeflective lesions on en face OCT. And with ICG, these lesions also co-localize. You see late hypofluorescence with ICG due to disruption of staining of the RPE from the ICG dye. And in addition to the hyporeflective spots, you can see the hyperreflective dots, which actually co-localize at the level of the outer nuclear layer and are immediately on top of the hyporeflective spots. And with time, of course, you'll see resolution of these spots and dots, both with en-face OCT and with fundus autofluorescence. And here you can see the outer nuclear hyperreflective dots. They resolve, and so do the ellipsoid hyporeflective spots in muse. AMPI is another condition where en-face OCT can be very helpful. Here's a case where you see choroidal ischemia and flow deficits that co-localize beautifully with the outer retinal lesions that you pick up nicely with en-face OCT, and these resolve with treatment. I showed you some cases yesterday of neovascular AMD and pigment epithelial detachments in which we used en-face OCT and en-face OCTA to track the progression of these lesions from the edge of the PED throughout the entire luminal area of the pigment epithelial detachment. In some cases now, you can even identify the morphology of the neovascular lesion with en-face OCT, and you can see the development of polyps, as you do in this case with en-face structural OCT after 2 years of follow-up with this modality. Finally, I'll talk about atrophy. Atrophy is also a very important lesion that can not just be identified, but also quantitated with en-face OCT. And in this particular study, we were able to see the development of atrophy outside the area of neovascularization, similar to what Bailey was talking about in his case, in which neovascularization can actually be protective. And here's a case again where you see the atrophy outside the area of the neovascular lesion. It continues to grow. It continues to grow, but in the area outside of where the vessels are located.
David, we're just going to see if they can pop your slides back up, because
just put the slides.
Your time is up, but we'll give you the last.
I'm actually done.
We'll give you Vas.
So,
2 minutes from Vas talk.
I was actually on my last slide. So advantages of, did you guys see just the area of atrophy that's growing on the en-face OCT outside of where the vessels are located? So advantages of en-face OCT, they shows you the interrelationship of OCT lesions, the pattern of these lesions, and the level of these lesions on a coronal or en-face plane. Thank you for your attention.
Great.
Thank you. Thank you, David.
Thanks, David.
So with this, we move on to last talk of the session on color fundus autofluorescence by Srinivas Sadda.
Thanks, Vishali. Okay, so I'm going to talk about color FAF. These are my relevant disclosures, and because of the limitations of time, I'm going to focus specifically on applications in macular atrophy. So we know that autofluorescence really has supplanted color photography as the gold standard for quantifying atrophy in the context of clinical trials, and it's not surprising because these atrophic lesions appear with great contrast, right? They appear as these dark or black areas, very similar to the optic nerve in terms of their appearance, and that makes it easy to quantify. And so we can use this type of approach to track the enlargement of atrophy over time in clinical trials. The challenge, though, is that atrophy doesn't always appear dark. Sometimes it can appear kind of grayish rather than black, and we've often wondered what's going on here, and here's yet another example. And in fact, we've recognized this type of appearance for some time. In some of the work that Frank Holtz and colleagues had done where they described these different patterns of autofluorescence around the atrophic lesions, I will highlight one particular pattern, this trickling pattern where the atrophy characteristically has a grayish rather than blackish appearance. And in fact, we've been very interested in these autofluorescence patterns per se, because certain patterns appear to be associated with faster growth, the banded and diffuse patterns, for example. But as it turns out, patients with trickling phenotype actually have the fastest growth. So there's something there that's worth us better understanding. And when people have dove a bit deeper to understand what is the source of this grayish appearance, it turns out that there appears to be, in these cases, the subretinal hyperreflective material in the bed of the atrophy that appears to be contributing to this grayish or less black appearance. And this actually is an issue for us in reading centers, because it actually can affect our ability to delineate the atrophic lesions. So to understand a little bit more about the origin of this material, we have to step back for a second and understand about the origins of fundus autofluorescence, because I'll explain why color autofluorescence is relevant. So we know that the retina and the RP contain many fluorophores, and when we're talking about clinical autofluorescence imaging with the commonly used blue and green light sources that we use, most of the autofluorescence signal is coming from lipofuscin. At the same time, though, it's not all coming from lipofuscin. There are other relevant fluorophores. So really, we'd really like to be able to get at resolving these different fluorophores. We'd like to know what's going on. And there are ways you can do that. One of the approaches is fluorescence lifetime imaging, but another approach, maybe an easier approach, is to discriminate based on emission wavelength. And that's what color autofluorescence is all about. And I'll talk a bit more about that. So again, this is sort of a mock-up of what I've just explained with autofluorescence imaging of the retina. Yes, the main fluorophore is lipofuscin, but there's a whole host of other minor fluorophores, flavin, adenosine, dinucleotide, AGE, collagen. These are all relevant. Now, when we're doing clinical autofluorescence imaging and we're imaging using light that's close to a 500 nanometer wavelength, you can see in this plot that most of this, I guess I don't really have a pointer, but most of this is coming from A2E and lipofuscin. But if you could actually use a shorter wavelength, go back to about 450 nanometers, you actually start to excite all of these other fluorophores a bit more. So again, if you use a standard 488 nanometer device, most of the return signal is actually coming in orange and it's lipofuscin. But if you go to a shorter wavelength light source, more blue light, you actually not only get the lipofuscin return, but you also get more green return signal, more with regards to these other fluorophores such as AGE. So that's what color autofluorescence really takes advantage of. It says, well, since we know that we can actually get both green and red return signal that equates to these different fluorophores, we just need to use a color detector rather than just a black and white detector to detect both this green and red emission and actually resolve them. So that's what we mean by color autofluorescence imaging. We're talking about the emission wavelengths, okay? So this is now possible with new technology with the CenterVue AIDEN device, which does utilize this shorter wavelength light source. And I want to show you some illustrative images. Here is a patient with geographic atrophy captured with the typical 488 nanometer autofluorescence device, and you can see the 450 nanometer autofluorescence image is shown in grayscale here. And again, I wish my pointer was working, but I will show you that it's almost actually harder to see these areas of atrophy, again, because there's a lot of, I'll show you minor fluorophores in that area. In fact, if you display this using the color autofluorescence technique, you can actually see, oh, thanks, Vishali. You can actually see that there's a lot of green in there. So a lot of the reason why you can't make out the atrophy is because of that greenish material, which represents activation of some of these minor fluorophores. So we had a number of questions. Once we saw that, aha, we have a method now that we actually can separately identify these other fluorophores. We wondered, how frequently do these regions of macular atrophy actually show these minor fluorophores, and what are the anatomic correlates? We've presumed that they correlate with subretinal hypertrophic material that I showed in those early studies, but is that truly the case? So this was an early pilot study that we did of patients with geographic atrophy, and we developed a technique which is now available in the device to basically especially selectively highlight and extract the green, primarily green emitting components. So this is basically the green emitting components in the image are highlighted in green in this illustration. So this is just a summary of the cohort, and basically what we observed was we observed three patterns overall. We observed a pattern where we saw these little chunks of green emission fluorescent component signal, and these did in fact correspond to these chunk-like areas of subretinal hypertrophic material that could be present within the bed of atrophy. Then we saw other cases there was more like a plaque-like sheet of this type of subretinal hypertrophic material. This is sort of the type 2 pattern. And finally, we certainly saw atrophic lesions where we saw nothing in the bed of atrophy, in fact, as in this example. Overall, we observed that over 50% of the cases had some of this green fluorescent material in the bed of atrophy, and this we speculated that this might correspond to age that could accumulate in, or advanced glycation end products that can accumulate in soft drusen. But this is going to be a topic, I think, of future study. The second question that we had was, does this increased activation of these minor fluorophores, this green material, actually impair our assessment of the atrophy in terms of trying to quantify it, especially with the 450 nanometer blue light. And to do this, and then we also question, well, if that's the case, if we isolated just the red signal, will that actually help us? And so to address this question, we did a second study, and in the second study of eyes with GA, what we did was we did the inverse. We isolated the red emission component as opposed to the green emission component. So this is the red filtered autofluorescence image. And this is sort of the comparison. Again, you see the standard autofluorescence image we're used to seeing. You can see again that when you allow the green fluorophores to actually take a larger role, it's harder to make out the atrophy. Pretty easy to appreciate. It's easy to see that that's green. And if you look at the red, then it really comes out. So we actually found isolating the red actually to be a very effective technique. In fact, if I go back for a second, you'll see there's some areas where even on the green, in the standard autofluorescence, they're hard to see. Easier to make out actually with the red is what we found. So these are just more examples of that. And so we then actually look to see in the reading center, does this actually have an impact on our ability to reliably grade and quantify atrophy? So what did we find? Basically, these are Bland-Altman plots. Look at the difference between graders. And you can see that the graders kind of struggle. There's a greater sort of variation when you had just the green, sort of, if you didn't isolate or remove the green component. But you can see the repeatability dramatically improve when you focused in on the red component. In fact, actually, it was a little bit better than using standard blue light autofluorescence imaging. So these minor fluorophores actually seem to be the major culprit. They actually were the things that were affecting our repeatability. And in fact, they really affected the measurements, because you can imagine if you have all of that green material in the bed of atrophy, it kind of makes the atrophic lesion look a bit smaller, and that's what we saw. The atrophic lesions seemed to measure smaller when you didn't actually remove them, but again, they appeared actually a bit larger if you use the red signal alone. And so we actually think this red component is super useful for assessing atrophy in these patients. And again, the fact that we observed it to be larger is not surprising, because you can see with standard autofluorescence imaging, some of these areas, because of that debris that's in that bed of atrophy, actually makes it harder for us to figure out where the atrophy ends and begins and ends. It's much easier with the red filter approach. So to summarize, I think color autofluorescence is a potentially a useful technique for enhancing contrast. It allows us to discriminate between these fluorophores. It's really, I think, potentially exciting in terms of studying a variety of diseases. I've shown you applications to atrophy, but I think there are a whole host of other diseases where we're now studying, especially inherited diseases, where I think being able to resolve different fluorophores could be of interest. I want to finally acknowledge my fellow Enrico Borelli, who did this great work. Enrico's back at San Raffaele in Milan now. Thank you very much. And so now we actually are at our discussion and actually open discussion section for questions from the audience for any of our speakers.
Thank you. Nice this is a question for Dr. Bailey, and two parts. One, do you envisage that this dense B-scan OCT and this flow parameters is going to become a more important entity of measurement and prognostication than simple structural OCT for RAP lesions as well as mactal lesions, as Macula also trying to predict whether these lesions will go into atrophy or the neovascular component. The flow characteristics as a way of prognosticating treatment or instituting early treatment.
I'm having trouble hearing everything you said. Is the question are flow characteristics going to become more relevant in terms of
more important than structural OCT in predicting treatment prognosis or monitoring treatment?
Just based on my own experience, I think not anytime soon. It's really hard to look at the flow and tell whether there's leakage, and so I really think you need both. So yeah, there hasn't been much success where people have actually looked at the angiographic flow patterns, tried to quantify those and predict whether those lesions are active. Eventually that may come, and maybe with the higher resolution that I showed, that's I think a little more possible, but currently I think you need both.
Would you say that be useful in Mactal? Dr. Jaffe or Dr. Sarraf?
Yeah,
again, I don't think we have enough information. I think once we start applying some of these techniques, for example, the high density to the MACTEL lesions, I think we'll learn more about whether they're predictive. I think it's really early on in the process. People are just now starting to look at OCTA in MACTEL lesions to identify the vessels, and we're finding that there are abnormal blood vessels in the clumps of reflective material that are overlying the retinal pigment epithelium, and I think that by better quantifying those areas, those seem to be correlated with less rapid growth, with more rapid growth of the lesion. So I think that by applying those techniques in MACTEL, we can identify lesions that may be more likely to grow more rapidly, and those may be lesions that respond better or worse to some of the treatments like the CNTF that I was mentioning.
So it looks like, I know there are more questions, and so I'd suggest that we take them, we'll take them to the side, only because we have the lunch symposium. Our symposium finished on time, but we started 10 minutes or so late because of the previous symposium. So I apologize to everyone. I know there are questions. We'll all stay over to the side to address them, but we'll have to give way to the lunch symposium. Thanks to all of our speakers. Thank you.